Mike, you've done a urologic oncology fellowship. So in your big group in Virginia, how are you guys dealing with the chemotherapies? Do you have somebody that's brought in? Are you giving it personally, or?
We're not giving it personally. We do have we've kind of established our own little prostate cancer working group for our region. So we have radiation oncologists, we have a specific GU medical oncologist that did his training at Sloan Kettering. And we all kind of work in collaboration to decide how we're going to refer patients, when we're going to refer. You know, there are certain patients that become castrate-resistant with metastatic disease that have such high volume disease that they are really more appropriate candidates for cytotoxic therapy, I think, up front than giving some of these oral agents. And so what we've been doing is we just kind of organize it in that fashion. We utilize a lot of the newer oral agents, of course, in the first line settings, and then whenever it's time, and there are certain avenues for that, looking at hemoglobin status and looking at their performance status, looking at all these things, taking into account that they may need that extra help. And I think by setting that up, which has taken some time to set up and get everyone to work together, especially whenever you're under 3 different umbrellas. You're not under the university setting where it's a lot easier to kind of somehow get these things organized. We're having to set them up with a private practice here and a private practice there and our private practice. Once you get all these organized, it actually makes the flow a lot better.
Is that what you're finding at Winthrop? I mean, I know you guys have a multidisciplinary approach as well.
Yes, I mean, at Winthrop, we have a very close collaboration with our medical oncologists, and the key point person for communication is our nurse navigator, who often goes with the patient to see the medical oncologist and will feed back what the plan is, and so the communication there is strong. Also, when I was at Columbia Medical Center working with Dan Petrolak, we treated many patients who were docetaxel failures with carbazitaxel, and for patients, particularly the M0 patients, there are trials at Yale, and Dan Petrolak and I will often collaborate to have patients assessed for their eligibility to enter various trials. We give Provenge in the office, in the urology office, and actually I would love to see urologists as part of their training to do a dedicated time period in medical oncology, because I think a lot of urologists are very frightened about managing these patients, and that is exacerbated by the speed at which the advances in medical oncology, particularly in castrate-resistant prostate cancer, are happening. And I think if urology residents were able to spend 3 or 6 months in dedicated medical oncology clinics, it would certainly help break down some of those fears about managing these patients.
Now, Neil, you are one of the few people that I know that have given in your own clinic personally a significant amount of some of these chemotherapeutic agents, like docetaxel as well as cabazitaxel. Why is it that you think, I think Dr. Cheatham's point is well taken, there is an educational process, there is this fear. You've been able to do it successfully, and you're one of the few urologists in an independent practice setting that does do it and continues to do it. And so how do we continue to push this envelope that, number one, urologists, they need to be involved, but as we move forward with healthcare reform and however people are going to get paid, whether it's disease management, episodic care, we obviously need to develop different relationships, different business models. Tell us a little bit about your experience in South Carolina.
Well, it's a great question, Raul. How do we do this? I think, as Philippa says, we have to start it at the residency fellowship training level, and we can't just be completely focused on only our surgical techniques and our surgical skills, which unfortunately, when you come to AUA and everybody's, with their 3D glasses on, they're just watching those robot films. But not everybody can be the robotic surgeon in a large group. You need folks to subspecialize and collaborate. And I'm a huge believer in subspecialization and collaboration now. And if you think about advanced GU oncology, and Oliver said this and everybody else I think has agreed, we've had this incredible number of breakthroughs. And we look at our own literature from the Journal of Urology, British Journal of Urology, Urology Times, it's all about these wonderful advances in systemic therapies. So how do we create education, and how do we have somebody in the community do it? In my own situation, it can't be a dalliance. You have to be dedicated to doing it. You have to say, if I'm a 5-man group or if I'm a 50-man group, you can do it. It just has to be someone who wants to do it. My analogy oftentimes is you don't need 50 guys doing the robot or 50 guys doing complex pelvic prolapse repair. You need 1 or 2 who really want to pursue and champion systemic therapies. So that's really what I did for the last 10 years, and I'm no smarter than anybody out there. I just liked it. I saw the unmet need, and I've actually found it remarkably rewarding. Especially that I can really offer patients something beneficial. Being honest about it, it's not the most lucrative thing. It's not the most remunerative thing because of our compensation formulas. We still are more on getting paid for volume and getting paid as proceduralists. But I think as we change in our healthcare management system to a more capitated structure, we have to manage prostate cancer in its entirety. People are living longer, they're living higher quality life. And that was a lot of the motivation for me. And thanks to guys like Oliver, who came up with, cabazitaxel. Everything he said is spot on. I mean, it is a well-tolerated drug, less neuropathy, growth factor mitigates the risk of the neutropenia. And we're looking at head-to-head trials. It may ultimately be first line, we don't know. But I've really loved it. I encourage my colleagues in independent practice of urology to really find someone to champion it.
And I agree with Neil that you have to have a passion to want to manage these patients, because these patients, you cannot address the issues in a 5-minute consultation. The patients need time, they're very anxious about the progression of disease, they need to be educated about where their management program is going, and they need repetition. And it's not possible to do that in a 5-minute consultation.
No, I think we've all talked about this before. It's just this concept of having a physician champion, understanding the disease state, whether you take the initiative and you set up your programs to treat yourself, is what you can do that. But if you can't do that, then at least be smart enough and sensitive enough to send them to the medical oncologist to get them treated early. Because we all know, and I think this data is becoming more and more complete, is that PSA, although not a good surrogate marker for survival, is a good marker for when to treat and volume of disease. And we all know that the lower the PSA, less tumor volume, these patients, if we can get them treated earlier, will do better.
I think as well the key for these patients is to use your team properly. And if you have a physician's assistant, a medical assistant, a nurse that's well educated, they can do a lot of the work for you. They can give the hormone shots, they can give the education on bone health, they can answer a lot of the patient's questions.
So that's a great point, and Oliver, I know your go-to nurse, or whether it's an advanced practice provider, which I think is the nomenclature we've moved towards now, are going to be key functionaries in making these CRPC clinics more effective. I agree with that absolutely. We have a manpower shortage in urology, medical oncology, so these advanced practice providers are absolutely instrumental. They do a lot of the really hard work that makes it successful.
One of the things that I wanted to kind of bring to your attention, because I think it was a very wise point about sort of the passion and dedication that it requires. A lot of medical oncologists are not equipped for prostate cancer. And it's, I think, a long-standing issue in medical oncology field that there's so much emphasis on the lymphoma, the leukemia, the breast, the colon, the lung, that prostate kind of is a little bit forgotten. There are individuals like Dan Petrolak, now at Yale, who's fabulous in how he does it. But medical oncology is not as good as you might think unless you have somebody dedicated and focused. So one of the things I would love to see happen more nationally is to create these kind of aggregates of expertise, like you had mentioned, that you have somebody in your group that is working with the medical oncology group closely. And if you can do that in a segregated way, you really bring expertise. I actually think it's not so much the specialty. I think there are people like Neil who do a fabulous job because he's got the passion and dedication. And then you have other medical oncologists who have the passion and dedication, but it's not for everybody. And you just got to find and develop your little group, your little niche, and then the patients are really the beneficiaries.
Don't you think as well that we need to get away from who owns the patient, either urology or oncology? We need to work together and not hold on to patients. If we're not able to manage these patients with castrate-resistant prostate cancer, then we shouldn't be tardy in referring them on to somebody that can.
I would certainly agree.
And I also think there's an unmet need for those people who want to be passionate in their group, like Neil says, to take that role. If it's not in fellowship or residency, where do they learn? And I think that's why panels like this are good for education. And maybe this is where AUA or LUGPA can step up and say, I know you guys taught a course a while ago on advanced prostate cancer, but I think there's got to be a place that the guy in the group of a 5 or 6 man group says, I want to be that champion. Where do I go to learn about that? You know, we need to help support that as well.
No, I mean, and again, I think that's the challenge, and I think, as all of us, I think, would agree, is that castration, advanced prostate cancer, once these patients get on hormonal therapy, this is a different animal, and you will have people, rightfully so, that are going to be robots and are really good at managing localized disease, but I think there has to be some willingness to understand that, hey, maybe you're not going to be, that robot guy is not going to be the same guy that's going to manage castration-resistant prostate cancer. So let's stay in